So hello, everyone, and welcome. Thanks for joining us today for this webinar in our ACTA2 series, focusing on the smooth muscle dysfunction syndrome and cardiology, an insight from a decade of caring for patients with SMDS, or the smooth muscle dysfunction syndrome. This webinar is in partnership with the Genetic Aortic Disorders Association Canada and the John Ritter Foundation for Aortic Health. We are really excited to be hosting this together. I'm Chrisanne Campos, the Scientific Director with GADA Canada, and with me, co-hosting with me is Ellen Hostetler, the Chief Science Officer with the John Ritter Foundation for Aortic Health. For those who don't already know, GADA Canada is a patient advocacy organization in Canada supporting research and education of genetic aortic disorders. Our support for ACTA2 or the SMDS research is through our support for the Montalcino Aortic Consortium, which is an international patient registry for genetic aortic disorders. It's an international collaboration of clinicians working on a patient registry for research. If interested in participating in this research, I have an email. That's the mac@the-UT Health email. And if you have any other questions regarding MAC, feel free to contact GADA Canada, myself, Chrisanne, anytime. I'm just happy to introduce you. We're so honored to have Dr. Angela Yetman, a pediatric and adult cardiologist, joining us today. She is a fellow Canadian who's right now in the Children's Hospital in Omaha, Nebraska. She's a professor of cardiology and program director of the Marfan and Thoracic Aortic Disease Program. Dr. Yetman's focus is on congenital heart disease and the diseases of the aorta. She has over 20 years of experience caring for patients with disorders of the aorta, including ACTA2, and she works really closely with cardiothoracic surgery and vascular surgery divisions in order to provide comprehensive care of patients with aortic disease. Dr. Yetman is also a member of the Montalcino Aortic Consortium. She's an executive committee member steering the research as well as actively enrolling patients into the registry for research. So thank you so much, Dr. Yetman, for being here with us. Before we hand over the talk to you, I'll just hand over to Ellen to say a quick few words.
Yes, thanks, Chrisanne, and thank you all for joining us today. As she said, I'm Ellen Hostetler, and I'm the Chief Science Officer for the John Ritter Foundation, which, as most of you probably know, we exist to support research, education, and advocacy for aortic disease all across the world, but also, most of us are based here in the US, but we do also work with patients in other countries abroad. And we do have a specific focus on, or a special focus on ACTA2 and SMDS because of our longstanding relationship with Dr. Diana Milowitz, who was the first person to identify smooth muscle dysfunction syndrome and also ACTA2 in general as a cause of aortic disease. And so over the years, we've been able to raise hundreds of thousands of dollars for research on this condition, thanks in no small part to one of our board members, Nancy. I don't know if she's here today, but a special thank you to her. She sadly lost her daughter to complications from SMDS, but has really done a lot for this community to raise money for research, including for the animal model for this disease, and also the upcoming clinical trial that we'll be excited to share more with later. And I also just wanted to quickly shout out Maura, who's joining us today, Maura Borio. She works for Dr. Milowitz in her lab. A lot of you probably know her. She's joined us today to answer any questions about participating research, ACTA2, registry, genetics. She's an all-star. We love her. So we're so glad that she's here too to help out in the chat.
Thanks everyone for coming. It's great to be here. And as Ellen said, I'll be in the chat to help with anything research related. So.
And I think if you can go to the next slide, Chrisanne, sorry. This is just a quick disclaimer about that this is a session that we are going to be offering information on, but of course, please do not take this as medical advice. Work with your own providers and clinicians. If you need advice on how to find a good one in your location, you can reach out to Chrisanne in Canada. Us, if you're US based, we're happy to help you connect you with experts, but please don't make medical decisions based on the information that was presented in this webinar. And if you have questions about that, feel free to reach out to us. Hopefully everyone knows how to use Zoom because we're so far past living in an onward world. But if you don't, there's a Q&A box and there's also a chat box. Feel free to introduce yourself. And with that, I will hand it over to Dr. Yetman. And oh, sorry, missed the last. But we can.
Okay. Are my slides sharing, Chrisanne?
Yes, yes.
Okay, wonderful. Well, thank you. I'd like to start by thanking Chrisanne and GADA Canada and Ellen with the John Ritter Foundation for this opportunity to speak here today. And I'm going to share with you what I've learned about ACTA2 aortic disease and smooth muscle dysfunction syndrome over the last, I'd say, couple of decades, although we didn't know about the specific disorder until after 2007. So starting off just very general, we're going to be talking about the aorta today. The aorta is the main blood vessel in the body. It arises from the heart. It heads up towards the head, gives off some branches to the brain and arms, and then turns a corner and then heads down towards the feet. We have different labels for different parts of the aorta, and these are quite valuable. They allow us to talk about where disease is occurring, but they also are important because aneurysms or areas of enlargement in these different areas may behave differently and are followed differently in terms of ongoing monitoring. So we have the aortic root, which is the part closest to the heart, right by the aortic valve, and that is sometimes referred to as the sinuses of Valsalva. And that area is a common area for dilation, and it is well seen on echocardiography. So if someone has an aneurysm that's confined just to the aortic root, that's somebody who may be able to have echo be the mainstay of surveillance of their therapy, of their monitoring. They may still need, or they will still need, periodic imaging to look at the whole aorta, but a lot of the work can be done with echo. The ascending aorta sits above the aortic root, and then the aortic arch above that, and that's up in the neck area. These areas can be seen well on echo if the lab is using a specific aortic protocol, and that is not routinely used in all labs. And so the possibility for following with echo is there, but you need to make sure that the lab is familiar with how to do that. And then we've got the descending aorta that heads down towards the toes. This can't be seen well in its entirety on echo because the airways are in the way. And so that's why we use CAT scan MRI to look at the descending aorta. Below the diaphragm, we've got the abdominal aorta, which can be imaged both with ultrasound or CT or MRI. Well, when we see a patient, we want to know, do they have aortic dilation? Is their aorta bigger than normal? Do they have an aneurysm? And in order to answer that question, we have to know what a normal value is for the aorta. And the aorta has a range of normal values, and these vary by site of the aorta. And so the aorta tends to be bigger in bigger people. It tends to be bigger in older people, and it tends to be bigger in males versus females. And so when we see a patient, we measure their aorta on echo or CT, MRI, and then we compare it against a normative database matched for age, gender, and body size. And then from that, we calculate what is called a Z-score, or in Canada, a Z-score. A normal Z-score is less than 2. So we want the patient to have a Z-score ideally of less than 2. And that's something that can be tracked over time. Well, what is an aortic aneurysm? This shows a simplified picture. Basically, it's an area of enlargement in the blood vessel. And as the vessel enlarges, you can see the walls get thinner. And as the walls get thinner, that can interfere with the integrity or strength of the blood vessel and can predispose to a tear in that thinner wall. Now, you'll hear the phrase aortic dilation or aortic enlargement or aortic aneurysm used, and strictly speaking, we do use those terms interchangeably, but that is not necessarily accurate. An aortic aneurysm implies that the area that's bigger than the surrounding vessel is at least 1.5 times bigger. Well, before we talk about ACTA 2 specifically, it's important to have a good understanding of what the aorta looks like on cross-section. And here we are looking at the different layers of the aorta. So the aorta has 3 layers. It has this innermost layer called the intima. It has this middle layer called the media, which is muscular in nature, and then this outer layer called the adventitia. And it's the smooth muscle cells that reside in this middle layer that are affected with ACTA 2 gene variants. So in terms of smooth muscle, we have muscle different places in our body. We're all familiar with skeletal muscle. Those are the muscles in our arms and legs. They contract and relax. They propel us forward. We have the same thing in other parts of the body, in the eyes and the intestinal tract, the bladder, the bowel, the uterus. But in those instances, there is what's called smooth muscle. And smooth muscle also normally should contract and relax. And if you have an abnormality of smooth muscle, you won't get that normal contraction and relaxation, and that can lead to some problems. Now, as I mentioned, the aortic media, that middle layer, is rich in smooth muscle. And so if you have something like an ACTA 2 condition, that smooth muscle is going to be impacted. Well, what happens in the instance of an aortic aneurysm and aortic dissection? Dissection refers to a tear in the vessel wall. So the aneurysm implies that the vessel is bigger than normal, like we saw in that other slide. And if that larger vessel comes under increased pressure, there can be a tear in this inner lining of the aorta, and then blood can go in between the layers of the aorta. And what that does is it allows that buildup of blood to push down on this inner layer, and that can compromise flow to the brain, flow to the heart. And so aortic dissections are very problematic. If the dissection occurs in the ascending aorta, that's called a type A dissection. If it occurs only in the descending aorta, that's called a type B dissection. Now, a type A dissection is a surgical emergency. We get the patient to the OR as quickly as possible because we know survival is limited if patients don't have surgery. A type B dissection, however, has the potential to be managed medically with tight blood pressure control, and then to follow the patient, and the patient may be followed for a considerable period of time, even potentially for the rest of their lives, and not require surgical intervention. Well, when we talk about aortic aneurysms, there are many different kinds of aortic aneurysms. Here we have a picture with a patient who, strictly speaking, does have an aortic aneurysm here of the aortic root, and then they also have an area of enlargement here in this descending aorta. And in terms of the cause of aneurysms, there are a number of lifestyle type risk factors that in and of themselves can cause aneurysms. Things like high blood pressure over a long period of time, smoking, high cholesterol, radiation therapy to the chest can affect the aorta, bodybuilding over a long period of time, and then use of stimulants like cocaine and methamphetamines. All of those can affect the aorta and lead to changes. There are also some inflammatory and infectious conditions of the aorta, which are relatively rare, that can also cause aneurysms. But the aneurysms we're talking about today are genetic aneurysms that fall under this class of heritable thoracic aortic disease. And that is where ACTA 2 mutations or variants fall. And so, here we go. ACTA2 variants, as we mentioned, the ACTA2 gene encodes for a protein in the smooth muscle. And so if you've got a pathogenic variant in ACTA2, you may not end up with a normal muscle product. It is the most common genetic cause of familial thoracic aortic aneurysm disease in patients who don't have outward manifestations of another condition. Some of the variants, of the ACTA2 variants, are associated with other problems, such as early onset coronary artery disease and stroke. It has been said that half of all carriers, so half of people who have inherited an ACTA2 genetic variant, will not have any significant aortic disease. We do need to keep in mind, though, that the aortic disease is age-related, and so even if a patient doesn't have aortic disease at age 40, that doesn't mean that they're out of the woods, and they certainly could go on to develop disease later on in life. Of those who do have impact of the gene such that the aorta is not normal, patients are more likely, if they have a dissection, to have a type A dissection compared to a type B dissection. The risk of having an aortic vent, which is either a dissection or surgery to prevent a dissection, when one reaches 85 years is 76%. So by the time you get to 85 years of age, you are more likely than not to have needed surgery on your aorta if you have ACTA2 disease. We do know, like many of the other genes, that aortic vents are more common in males than they are in females. We also know that patients tend to run into problems with tears in the aorta at a size smaller than 5 centimeters. And so the current surgical recommendation is for patients with ACTA2 genetic variants to have surgery at 4.5 centimeters. And this early surgery is suggested in order to prevent aortic dissection. Well, we do see some additional features in the setting of a pathogenic ACTA2 variant. So it's not just the aorta that's abnormal. We can see some changes in the vessels in the brain, and that's shown up here in the left upper picture. This is a picture of all the vessels in the brain, and this patient has some enlargement of the bigger vessels and then a lot of narrowings of the smaller vessels. And this picture has been given the name moya moya, which translates to puff of smoke. And so this is something that we see quite commonly in patients with SMDS, which I'll talk about in more detail, but it can also be seen in some of the other older patients with ACTA2 variants. Patients can have abnormalities of the eyes. They can have something called iris floculi. And what you might notice is that the pupil on looking at the eyes is not perfectly round. It has a bit of an irregular contour. And so certainly when we're seeing somebody with an aneurysm, that's something we examine for as it's a clue to what the underlying diagnosis is. Probably the more common eye finding are these fixed and dilated pupils. Patients have large pupils, and when you shine a bright light, the pupils don't constrict like normal. And that's because the smooth muscle in the eye is similarly affected as is the smooth muscle in the aorta. If they've had the chance to see an eye doctor and had a dilated eye exam, then it may be noticed that they have a lot of tortuosity or twistiness of the vessels at the back of the eye. And then finally, some patients, although certainly not the majority, will have a finding of the skin known as livido reticularis, which is this purplish discoloration on exposure to cold. And this is sort of a profound example. It's often much milder than this. ACTA2 variants in pregnancy. Pregnancy is a tricky time for some of these patients. Studies have been done where they looked at all patients with an ACTA2 pathogenic variant, and what they found is that 6% of pregnancies were complicated by an aortic dissection. So it is a more risky time, the time around pregnancy than other times of life for females that are affected. As a result, we do pre-pregnancy screening. We look at all the blood vessels from head down past the groin to make sure there aren't any aneurysms prior to pregnancy. And then if there are, note what size they are. Are they nearing surgical intervention? Is it safe for the woman to get pregnant? And then we follow them very closely during pregnancy. We routinely use a class of blood pressure medication during pregnancy known as beta blockers. Not all beta blockers are safe during pregnancy, but the ones we use are safe for both baby and mother. Certainly in the US, those would be metoprolol and labetalol. We typically follow these women monthly with echocardiograms to ensure that their aorta is not getting bigger. From our limited experience of ACTA2 and pregnancy, we do know that if a woman increases the size of her aorta more than 3 millimeters during pregnancy, that is a warning sign or a sign that it's an unstable aorta. And if that's the case, we actually have the women meet with a cardiothoracic surgeon prior to delivery, and we ensure that delivery takes place in a hospital that has both high-risk obstetrics and cardiovascular surgery available in case the woman does experience a dissection at the time of delivery. Just briefly, ACTA2, certain ACTA2 variants shown here can also be associated with premature atherosclerotic coronary artery disease, which is a focus of research in Diana's lab, which I believe Mara is intimately involved in. And certainly if you have any questions about this, you can direct those her way. This is a CT scan from a patient I follow with ACTA2 disease, and he underwent surgery for an aortic aneurysm at a fairly young age. He was in his late 20s and then was getting serial CT scans to follow his aorta over time. And in addition to a new aneurysm, which he has here, he had a lot of calcific changes. This is calcium that's laid down in the aorta. And this is pretty pronounced for his age. And what this is atherosclerosis over time. And this can lead to obstruction of the coronary artery vessels or other vessels. Chris-Ann or Ellen already put a plug in for MAC, the Montalcino Aortic Consortium. So this is data that was generated from the consortium, which again is a group of physicians and scientists who have devoted their career to aortic research and under the direction of Dr. Milowitz, enter data into this registry with the assistance of their patients. And as a community, we've been very successful in using this data on these relatively rare conditions to generate information which is very helpful both for the patient and for us when managing these patients. And if I can direct your attention to the slide up here on the left entitled SMC genes, you'll see that ACTA2 here in green is this middle line here. And what this graph is displaying is the likelihood of having either an aortic dissection or surgery to prevent an aortic dissection over the years. And so what you can see is that by just over age 40, there's a 50% chance that a patient will have had either surgery to prevent the dissection or a dissection itself. And so certainly within this group of genes, it is not the most aggressive genetic disorder, but it's also not the least aggressive. So that brings us to the multisystem smooth muscle dysfunction syndrome, or SMDS. And that is typically associated with these arginine 179 mutations. These patients have a severe form of disease. They typically present in childhood, oftentimes in infancy. They typically have fixed and dilated pupils, so it may be noticed after birth that their eyes are not constricting normally, and that can lead to further investigation and the diagnosis. Or these patients can actually present prior to birth. We've had several patients who have presented in utero while still in the womb with a significant bladder dysfunction, and the bladder becomes significantly enlarged, distended because it doesn't contract normally, and that can lead to difficulties with delivery. These patients also have involvement of the vessels in the brain, like we talked about, that moya type picture. In terms of the cardiac features of SMDS, there are 3 cardiac features that we typically see, and we try to educate the pediatric cardiologists as to these features, so that if they do encounter a patient with one of these 3 things, that they'll be thinking, okay, is this an ACTA2 mutation or ACTA2 variant, and should I send this patient on to CV genetics? I'll talk about each of these. The first was a giant PDA, which stands for patent ductus arteriosus. So all babies are born with this blood vessel open, this PDA. And then normally that blood vessel closes off in the first couple of days after birth. And it serves a purpose. It exists because when the baby's in the womb, they're not using their lungs to breathe. And so it allows blood to bypass the lungs and go directly to the body. However, once they take a big breath after birth, there are several changes that go on in the body, which lead this to constrict and close normally. Now, oftentimes this remains open in babies who are born prematurely. And so we do see a lot of PDAs, but giant PDAs or aneurysmal PDAs, or a PDA that's referred to as an AP window type PDA, those are extremely rare and should lead one to suspect SMDS. And so in that instance, basically the smooth muscle is not constricting normally, and that vessel is quite large, usually short and large. Timely treatment for that is important, because what happens is that blood going off to the body then goes out to the lungs instead, and that causes congestion in the lungs, which can cause permanent damage to the vessels in the lungs and lead to what's called pulmonary hypertension. So this vessel can be closed either with surgery, and it's not a major surgery. It's actually in some institutions done right at the baby's bedside through the side of the chest, where that PDA can be closed, or in some instances it can be closed with a device that's delivered up to the vessel through one of the veins in the leg. And so this is just a picture of PDA closure devices. This is the coil, and this is another form of device. But again, a catheter just goes up from a blood vessel in the leg that goes through the heart, out the pulmonary artery, and then that device is delivered right there in that vessel with the goal of blocking it off, and then tissue will form around it, and that device stays in place for the rest of the child's life and doesn't cause any problems. Now, I will say that if the PDA is truly giant, it is often very difficult to close it with these type of devices, and so surgery is often required. So I mentioned pulmonary hypertension, which basically means that the pressures in the vessels in the lungs are high, and this likely occurs due to abnormalities in the vessels themselves, just like the vessels elsewhere in the body. Certainly a giant PDA will aggravate or compound this problem of pulmonary hypertension. This is something that can improve over time. We've seen patients who have had pulmonary hypertension shortly after birth, which then got better on its own. There are also many treatments out on the market for treatment of pulmonary hypertension. And then finally, aortic aneurysms in SMDS. This is a patient of mine with SMDS here, and all the red stars indicate where the aneurysms are present. So in this patient, they actually didn't have any involvement of the aortic root down here, but had significant enlargement or aneurysm of the ascending aorta, as well as this branch going off to the right arm, as well as the descending thoracic aorta and the abdominal aorta. And so this is something that needs to be monitored closely over time. And the way we monitor is with a combination of echo as well as another form of imaging, either MRI or what we use often is something called a flash CT scan, which is a CT scan with very minimal amount of radiation. And the benefit of that flash CT scan is it can be done without general anesthesia to sedate the patient. But different institutions have different protocols. They do what they're good at. Some institutions can get a good quality MRI without general anesthesia, where others are used to using different imaging modalities. And so here we have data on 3 patients of mine. And so they come into clinic, they get their echo or other imaging study, and we measure the aortic root as well as the ascending aorta. We also measure other areas, but these slides just demonstrate the aortic root and the ascending aortic measurements. And then we calculate the Z-score. And you'll remember I said a normal Z-score is less than 2. And so for this patient, she was diagnosed at 2 years of age, which is later than some. And this may actually be a patient who was born after or born prior to 2007, where we didn't have genetic testing for ACTA2. But her Z-score for her aortic root was only 3.4, so mild dilation, but the Z-score for the ascending aorta was +6. And over time, these progressively increased until she got to a diameter of 44 millimeters and had surgery at that time. This patient, I know, was born well before the ACTA2 variant being discovered, and she presented much later in life. She did present right in the newborn period with a aneurysmal PDA, but nobody knew what to make of it at that time, and it was closed and she was sent on her way. But again, developed significant dilation over time. And then finally, this little baby here, who actually started off with a normal aorta at 2 days of age. Her Z-scores were both normal, but then again, over time, they continued to increase. So that close monitoring and tracking of the Z-scores is important because the aorta normally increases in size as children grow. So you want to make sure the enlargement is pathologic, make sure it's not pathologic, not just a feature of normal growth. So when we have a child with SMDS and progressive enlargement of their aorta, and we believe that it's time for surgery or getting close to time for surgery, we're always trying to balance the risk of surgery, the risk of their aorta tearing versus the risk of a stroke. Surgery does involve putting patients on a heart-lung machine, which can affect flow through the vessels in the brain. And as long as those vessels are widely open, there shouldn't be any issues. However, if there are critical narrowings in the vessels in the brain, that it's important to know about those and try to time surgery so that you're in a lower risk time for stroke, and that you don't do surgery before there's really a need to in terms of the risk for aortic dissection. So this top curve here shows the risk of an aortic event, either surgery or dissection, over time in patients with SMDS. And as you can see, there really isn't, there is really minimal risk to the patient prior to 10 years of age. And then at 10 years of age, there's a rather steep increase in the need for surgery. And then over here, we see the risk of stroke. And again, it does increase over time, but it has long periods of stability where we're not seeing increases. So we do keep this in mind when recommending or trying to decide when to recommend surgery for patients. In terms of monitoring for SMDS, again, this is going to be institution specific, but we do either an MRI or flash CT from head to groin at baseline, so we know where the aneurysms are. We then follow the patients with echo every 6 months, and then we repeat the MRI or flash CT if one of the following occurs. If we can't see the aorta well in any of those segments on echo, if we have a concern on echo, something seems to have changed, or at 10 years of age, just because that's that high risk time. So you want to see the aorta again. If we're putting them forth for surgery, we want to make sure we know where all of the aneurysms are. And then immediately following a surgery, so that you have a new baseline of what things look like. And then once the patients have had surgery, we do this type of imaging every year thereafter. In terms of MRI and flash CT, again, there are risks and benefits. Well, there are upsides and downsides to both. The CT is a very quick study done within a heartbeat or two, whereas the MRI involves lying in the scanner for much longer and often requires some form of anesthesia for children younger than 7 or 8 years of age. In terms of medical treatment in general for all patients with ACTA2 variants, blood pressure control is key. It's the one thing or one of the few things that we can control. And for adult-sized patients, we want the blood pressure to be less than 120/80. And this is fairly aggressive compared to the general population, where they want your blood pressure less than 130/85. But with this, we do see much less in the way of progression of aortic dilation. For children run lower blood pressures than adults, and so we want that number even lower in children. Typically, we want it less than the 75th percentile, and so we can figure out where that is when the patient comes in for a visit and make sure that they're in that range. Now, having said that, high blood pressure is not usually an issue for children with this disorder, particularly children with SMDS. They typically run very low blood pressures, and if anything, we have the opposite problem of having them on medication because their blood pressure is low. So blood pressure medications are tried in order to minimize the stress on the aorta, and there are several classes of drugs that have been used, but none of these have been specifically studied in patients with ACTA2 mutations. They have been studied in other groups of patients who have aortic aneurysmal conditions that are hereditary, and each of them has been shown to be effective in some regard. Beta blockers, we know, decrease the risk of subsequent aortic dissection after initial surgery in all comers with aortic disease. Angiotensin receptor blockers have been shown to be as effective as beta blockers in slowing the rate of aortic dilation in children with Marfan syndrome. And then ACE inhibitors have been shown to actually work on the smooth muscle cells in adults with acquired aneurysms. So those are our mainstays of blood pressure control. And then in patients who have had surgery on their aorta, we do typically have them on statin therapy afterwards, typically the adults. Again, no medication has been shown specifically to work better than another medicine for ACTA2 variants. Medication should be started at a low dose, particularly children with SMDS, and one needs to monitor for side effects because, again, you're trying to have the blood pressure nice and low, but not so low that you decrease the pressure required to get past any narrowings in the brain vessels. Not all patients will tolerate being on medications. All adults should tolerate being on medications. Not all children will necessarily be tolerant of medications, particularly if their blood pressure is very low to begin with. And then we tell patients that they should avoid stimulant medications as well as stimulant drugs, smoking, which we know has an adverse effect on the aorta, and then a group of antibiotics called fluoroquinolones, and those are medicines like Levaquin. And these have been shown, at least in animal models, to cause aneurysms. And so we tend to stay away from those. Just a brief word on surgery for aortic replacement. In general, the logic behind surgery is that there's an area of the aorta that is bigger than it should be, and it is fragile. And so that is removed and replaced with a graft. And that graft is made of Dacron or Gore-Tex. It is strong. It stays with the patient forever, and the patient typically doesn't have any issues with it. This picture up on the left upper is a patient who had an aortic root replacement. And this one down here, the patient had a total arch replacement. And then finally, the bigger picture is somebody who's had their entire descending thoracic aorta replaced from just after the arch down to the diaphragm. And that is all I have to present today. So I don't know if there are any questions.
Thank you so much, Dr. Yetman. That was wonderful, as always. We did have a bunch of questions sent in, so if you're okay, I'll just jump in with one, and I'm sure Christiane can bounce off those as well. So I'm actually going to start with one that was last session that we didn't get to.
Oh, okay.
So Dr. Milowitz spoke with us last month, and I did want to add, I'm going to put it in the chat for everyone. That's a link to the specific portion where she talks about SMDS. Of course, the whole lecture is great, so view the whole thing, but I wanted to add that in the chat just in case anyone here missed it. But someone asked about losartan versus beta blockers. And I loved what you said about, there's no evidence, there's no been trials done in this specific population, because I think sometimes, people are used to being told, well, in patients with Marfan syndrome, for example, this is shown, but unfortunately, there's not a lot of data in ACTA 2 or much less SMDS, but they were concerned about their daughter. She's on losartan, she has SMDS, has significant ascending growth that will likely be repaired soon. But she was curious of, in the long term, a beta blocker would be better. Dr. Milowitz kind of leaned that way when she talked to us last month. But she had a feeling maybe it doesn't matter because she's going to have surgery soon on the ascending aorta. So doesn't make a difference for the future.
Yeah, I think what's most important is what the patient's blood pressure is running. So is it, if she's a child, which I'm assuming she is with SMDS, is the blood pressure, below the 75th percentile for her age? And so that's what we want. And if it is, then I think it becomes less important because you're not going to get her on a big dose of either medication. The trial that was done in patients with Marfan syndrome, which my institution was an active participant in, there was no difference between beta blockers and losartan, atenolol losartan. And if you look at the data on that, there were actually more adverse events, surgery and dissection in the losartan group, but those were few in number. And so it didn't meet any statistical significance. So we typically will use either in aortic aneurysm conditions in general. For ACTA 2 and SMDS, I do use beta blockers.
And I think the person who asked that question is on the call. So if you have follow-up, add it to the chat or send it privately to me if you have follow-up.
Right. So again, thank you, Dr. Yetman, for this excellent description on the clinical management of SMDS. There were a couple of questions regarding imaging. Just, a little bit of elaboration on MRI recommendations and just what the measurements of internal carotid arteries would be that could lead to a stroke, if you could comment on those.
Wow. Okay. So typically with SMDS, the carotid arteries are actually enlarged, and it's not the enlargement that we usually see patients run into problems with. It's the narrowings of the smaller vessels. And so, I've had patients with SMDS who have had symptoms, neurologic symptoms. There is a surgical procedure that involves augmenting the vessels in the brain. So there are things that can be done. And that really falls under the guidance of a neurosurgeon. So I would say there isn't actually a number. it's going to be where the patient, is the patient having symptoms? If the patient's asymptomatic, I don't think any neurosurgeon would intervene on the vessels. We do have patients on aspirin, and I forgot to mention that. So we do have children with SMDS on aspirin, unless they've got a bleeding history that they can't be on aspirin. And that, again, is to just try to maintain flow through those more narrowed areas.
Right.
We have someone who's asked about dilated cardiomyopathy. She says that my daughter was diagnosed at 10 days old, and this was a few years before she had an SMDS diagnosis. Are there other reports of patients with the same heart disease? Are they related?
So it depends. So the term dilated cardiomyopathy typically means that the left-sided pumping chamber, the left ventricle, is bigger than normal. And it can be bigger than normal in SMDS. That PDA that we talked about, that leads to recirculation of flow going to the left ventricle. And so that can cause dilation of the left ventricle. That should get better over time after the PDA has been closed. There are patients with Marfan syndrome who present in childhood with cardiomyopathy, and that's usually in association with abnormalities of their mitral valve. So I guess I'd need to know more about the patient. Do they have any abnormalities of the mitral valve? Did they have a big PDA? Was there a delay in closing that PDA? Those sorts of things. In terms of ACTA-2 involving the heart muscle itself, that is not something that I've encountered. Not to say that it may not exist in rare instance, but not something I've encountered.
And an important time to plug MAC, because if the more folks who are in this registry, the more we can answer questions like that, right?
Absolutely.
If you're out there, question asker, and you're not in the registry, please contact Maura so that she can get your case in there.
Yes, I will put the email in the chat. And as Chrisanne said, it's for any and all individuals with known genetic variants that cause aortic disease. So certainly everyone with R179 leading to SMDS, also other individuals with pathogenic or likely pathogenic variants in ACTA-2.
Right. And I have another question regarding medication. So this one's coming from a parent who has a daughter who's approaching teenage years, and she tends to miss her medication. So if she misses losartan, she's on losartan and she's missing it, would that have an effect on her aortic growth? And she's already quite big, like around 4 centimeters. What are the consequences of missing medication?
Right. Adolescence is a very difficult time. And that weighs into our decision as to what medication to have the patient on, because we do see more moodiness with beta blockers in the teenage years. And so I do oftentimes switch patients to losartan for the teenage years. Certainly, if somebody has symptoms of suicidal ideation, not that all teenagers do, but it's a difficult psychological time, and so those drugs have other effects on the body, and so we do consider that. To answer your question, there is some data that came out of Dr. Dietz's lab about some rebound enlargement of the aorta if someone was to miss medication. That has not been something, obviously you want to be on medication to control the blood pressure. If you miss a dose of medication, it's not ideal, but I'm not sure it's worse than not being on medication. So I try to, work with the patients to try to optimize compliance, setting an alarm on your phone, using things that adolescents are invested in.
Right. So would that change the timing of imaging then? If they're missing medications, would that call for an earlier imaging follow-up?
If I didn't have somebody on medication, I would certainly be more worried about them, and so might bring them back sooner for their echo.
Right. Right.
Also, the frequent visits are more important in that instance, just to re-emphasize compliance.
Yeah.
I just added another YouTube link in the chat since this topic came up. We had Dr. Petita join us last year, so this is last summer. She's a pediatric psychologist who deals specifically with children with chronic cardiovascular disease. So she talked to us about common challenges for children living with a disease like SMDS. So that might be helpful for some of you folks who have children in that age range to view. And then we just had a question come in the Q&A and said, my daughter has chronic lung disease, so she takes albuterol, and would these medications reduce the effectiveness of her beta blockers or her blood pressure medication?
Yeah, it's a good question. Certainly patients with lung disease, we try to get them off of the albuterol so that the albuterol is used only as a rescue therapy and it's not the mainstay of therapy, not a daily treatment. It basically does work in an opposite way to beta blockers. So yes, it does negate the effect, some of the effect of beta blockers.
Right. In terms of physical activity, Dr. Yetman, what would you recommend in, for heavy lifting or just ways to stay and exercise kind of guidance? Because it's important to stay fit.
Yes.
But for ACTA 2 patients or SMDS patients, what would be your recommendations? So
for ACTA 2 in general, again, we are big proponents of routine exercise. We know that exercise helps lower blood pressure. It's good for the vessels in the body in general. But we do discourage any exercise that falls into the form called isometric exercise or exercise against resistance. And so that would be weightlifting. And they've done studies, and when people are lifting weights, their blood pressure can go up to the 200, 300 range for that top number. And so certainly avoiding heavy weightlifting, minimizing any recreational weightlifting would be our preference. But staying active with cardio type activities. Our big issue here in the Midwest is football. A lot of people want to play football. We do discourage collision type sports. So that would be football and basketball particularly, but also, we discourage extreme sports and things like that. So, it's fine to play recreational basketball with your friends, but pushing yourself all out on a team is perhaps not ideal. With regards to weightlifting, people always want a number. Okay, well, what's my number that I have to stay under? And if somebody gives you a number, that's a bit misleading because your number is not going to be the same as my number. Again, so there's not a number for everyone. It's really dependent on your strength and where you're going to be increasing your blood pressure based on that resistance. So if I have a young, typically a young teenage boy who is going to lift weights no matter what, I tell them that if you can lift this amount of weight 15 times, then it's fine for you to, so 3 sets of 15. If you can do that, then it's fine for you to do 3 sets of 10. Mm-hmm. So they're not lifting to max. They've got a good reserve every time. And so that's my general rule. In terms of SMDS, obviously, that's a much more aggressive condition. And certainly the patients that I've taken care of have not been inclined towards athletics. Just they tend to have some physical, mild weakness, but staying active, I do think, is important for those patients as well. Right. That's great.
Someone asked in the chat here about it sounds like their child or daughter had a ASD and had a patch to fill it. I think they're asking, is this a complication of SMDS or something that's commonly found in these patients?
It's a good question, and it's a question that's been raised before. ASDs are very, very common. it's one of the more common congenital heart disease. So we don't think that it's specifically related to SMDS. That is just probably somebody who, had the ASD as well as SMDS. But again, through the data entered into MAC, the registry, we might find out otherwise. But at this point in time, we don't know of a direct link between those two things.
That makes sense.
Yeah. Yeah, so I don't know, Dr. Yetman, if this comes under medication, a question under medication, but for someone who's low energy, facing low energy or just lethargic, would that call for a change in the medication if they are maybe on losartan versus the beta blockers?
Yes. In very general terms, losartan seems to affect energy less than the beta blockers. So it is very common when one starts a beta blocker to feel quite fatigued. And we usually tell patients to put up with that for 2 weeks.
Right.
And then your body just acclimates and people then feel fine. But if there's a patient who's having ongoing significant fatigue on the medication, I would want to know where their blood pressure is running, because the blood pressure may be too low for them.
Right.
So certainly, if that's the case, then we would reduce the blood pressure and then follow that. We'll often do at-home 24-hour blood pressure monitoring, where a patient wears a cuff for 24 hours. It goes off periodically every 15 minutes through the day and the night. People typically don't like wearing these monitors, but it does give us a good sense of whether their blood pressure is well controlled.
Yes. Yes.
I had someone email me before this event and asked a really good question, and your presentation made me think of it because you've been able to follow patients over many years, which is really incredible. And pre even us knowing that this was a syndrome, knowing the genetic cause. So I think you might have some unique insight. This person happens to be female. She's living now in her, I believe, 20s. But she asked about, aging with this condition. And obviously we don't know a ton because there have been not a ton of patients identified, but so she specifically was asking about, female reproductive issues, or do we know anything about menstrual problems that females might have? Do we know anything about pregnancy, these kind of issues? So I don't know if you could just generally talk about your experience caring for patients as they aged from childhood to adulthood, and those that you might have seen happen.
Are we talking about SMDS now, or
So this person, yes, does have SMDS and themselves.
So I have taken care of patients with ACTA2 non-SMDS in pregnancy, and I have not taken care of anybody with SMDS in pregnancy. I did have a patient who was interested in pregnancy, but she had had previous surgery on her aortic valve and aorta. So she had a mechanical valve and she had a lot of residual aneurysm, and we discussed the risks and the benefits. We discussed the risks of pregnancy and the unknown, because we don't know how that I'm assuming the uterus will not contract normally to deliver the baby. And that's fine in and of itself, because then we're talking about a cesarean section, but the uterus still needs to contract to control bleeding after delivery. Otherwise, women can hemorrhage. So I don't know if anybody has experience with that. I would have to go to the MAC registry to see, but it's not something I've personally encountered, but I would have a lot of concerns.
Sure. And do you think that there will be more issues as people age? Like these things we might come across new things that, we don't, like the problems that we see in childhood might be different as people age and mature.
Certainly aging is not good for the aorta in general. Younger people have a healthy, very distensible aorta, and that is affected with ACTA2 mutations. And so age will only compound that. And that's what we see. And that's why we saw those Z scores increasing in patients over time. And so if we extend out that follow-up, we'll just see that trend continue, I expect. certainly any of the genetic variants that are associated with atherosclerotic disease will have more time to declare themselves as well. So that will be something that we'll have to look into more over time.
Very interesting.
Yeah, I agree with the follow-up, because there were a couple of questions asking how was the best way to stay ahead to avoid an aortic event. So I think it's really crucial to be on time with your follow-ups, appointments, and make sure you go to them, right?
Absolutely. And I would add no smoking, no vaping.
That's right.
Taking your medication and getting in, at least 30 minutes daily of physical activity, whether that's just, brisk walking or something else.
Yes, that's great. So I don't have, sorry, go ahead, Dr.
I was just going to say, I do think that there are a lot of modifiers, environmental modifiers, and that can really make a difference.
Right.
And so I think patients do have control over, a certain degree of their disease.
Yeah, that I recently there's a patient who has now a child where they both have SMDS, and I was asking Dr. Milowitz, will they have the same main problems? Because the father who's affected has very pronounced issues in one specific area of his body, and she said, we have no idea, and just like you said, it might be all these other genetic or environmental or lifestyle things that are influencing this condition. So really a big question as of yet, but luckily we can learn more.
Absolutely.
Yes. So I don't have any more questions, Dr. Yetman. Ellen, is there anything else you wanted to add before?
No, and I know we need to let you go here. One last person in the chat just typed something in. So she said, my son has an enlarged bladder, but has never had an issue with his bladder. And I know you're not a urologist, Dr. Yetman, but how concerned should I be with his bladder and something going wrong with it? He is almost 20.
Oh, fantastic. So he's had adequate bladder function. Then, if the bladder is not doing its job, then you're left with residual urine, and that sets you up for urinary tract infections. So if he's not had recurrent urinary tract infections, then it's working well enough. And we have no data at this time to suggest that is going to get worse over time.
Good. Well, then, thank you so much for answering all these questions. I know everyone's appreciative. When we posted this on our Facebook page, someone wrote, we love Dr. Yetman. She's the best. Her emoji. So you have fans out there. So we really appreciate you being with us today and sharing your knowledge and expertise and time.
Yes, thank you.
Happy to be here.
Thank you so much, Dr. Yetman. It was an absolute pleasure having you here. I just want to say this webinar was recorded, and so it'll be available on the GADA Canada as well as the JRF YouTube channels. So just stay tuned to your emails or even our Facebook and Instagram, Twitter channels for when the recording will be made available. It was great hearing from you, Dr. Yetman, the description, the clinical management. Absolutely. Thank you so much.
Yes, that's great. And I'll just add also that we haven't put this out publicly yet, but first news here next month on the 24th of April, Dr. Milowitz will be joining us again to talk through, at the request of you all, the molecular biology of ACTA2. So bring your learning hat if you would like to join us. We had a lot of requests for learning more about the atherosclerosis, the brain disease, and everything in between. So this will be at a layperson level, but I hope you all can join us, and you'll see an announcement about that in your email. This is also co-hosted with us as well as GADA. So we are excited to continue this series going forward.
Yes. And thanks, Maura, for joining us. Any questions about MAC, please do contact the MAC email or GADA Canada, and we'll put you in touch with the MAC group at UT Health. Thank you so much, Maura. Thank you, Dr. Yetman, again. And thank you, everyone, for joining us and sending in your questions. They always make these webinars very helpful.
Yes, absolutely. Thanks, everyone. Bye.
Bye.
Bye-bye.